This is chapter 31, Veterinary Anesthesia. Anesthesia is really a unique discipline. There are people that specialize, either a vet tech or a veterinarian that's actually specialize in anesthesia. So that's why we call it a discipline. We use it a lot, but it's very complex, it's very high risk, and it's actually very fast paced. We have to monitor these animals every 5 minutes to make sure that they are doing well and they're at the right plane of anesthesia. So, what is anesthesia? It is defined as the absence of sensation. We can tranquilize an animal, we can use light or heavy sedation, or we can do local or general anesthesia. General anesthesia is considered controlled death. So we put the animal right at that bridge of crossing over into no heartbeat, no breathing, no consciousness, and we just keep them there. So that's a little scary, and you should be a little scared about anesthesia. You should be aware that you are controlling death. It's something that you really need to pay very close attention to as you're doing it. For most procedures, we do want to get some muscle relaxation. Analgesia is pain relief, and we absolutely want to get pain relief when we're doing anything painful. And then there's a word called neurolept analgesia, which is a semi-conscious, non-reactive state, and we usually get that by putting a couple of drugs together, drug combinations. So they're not painful, so they're not reactive, and they're semi-conscious. Usually when we're doing anesthesia, we're going to use 2 or more drugs, typically 3, sometimes 4. Actually typically 4, sometimes even more than that. It starts with a pre-medication drug. Typically we'll start with something like acepromazine, if you've heard that before, and we'll add an analgesic like morphine. So we're going to use a neurolept analgesia. They're going to be conscious, but they're going to be pretty loopy. Then we use an induction drug. An induction drug typically is something we give intravenously. We can give a ketamine diazepam mixture, or we can give, and that can be actually given IM, or we can give propofol or alfaxan, 2 drugs that we give IV, and it causes the animal to drop very, very quickly through the different planes of and stages of anesthesia, so that we kind of miss the excitement period where their nerves are quiet in one area, but not inhibited in another area. And we'll go through that later. So that induction drug really brings them to the point where we can place a tube in their trachea and maintain them, this maintenance drug, with some gas anesthesia, which is the safest way to do it. So first we need to make sure that the pet is okay to go under anesthesia. So we're going to gather some historical information. You have to ask this. People don't really understand when we take their animal into spay. They don't put together how careful we have to be. And so we really need to know, has your animal been fasted? How long has it been fasted? And I want you to look in your book for recommendations. How long do you fast a puppy? How long do you fast an adult? How long do you fast a rabbit? You should know those things. We want to know what their current condition is. If they come in for a routine anesthesia or surgical um, procedure, like a spay or a neuter, we likely haven't seen them for a couple of months. We don't know if in the last 3 days they've had vomiting or diarrhea, or they've had a respiratory condition. We want to know what's going on today. Um, so they may have scheduled this months ago. What's been going on now? Are they current on preventive care? Because we're bringing them into the hospital. We want to make sure that they're safe. Is this a scheduled procedure? And what kind of medications are they on? Because that can interfere with what we're doing. Then we're going to move to a physical assessment. We want to make sure that we know that they are perfectly conscious, that they have perfect vitals and respiratory sounds. They have to be able to breathe in order to take in the gas anesthesia. We want to palpate their pulse. auscultate their heart, look at their body condition. Is there any weakness, a problem with their gait or lameness, where they're limping? Are they in recumbency, meaning are they not able to get up? Do they have any parasites, wounds, tumors, or lesions? Is there any discharge from any orifice? And what is their mucous membrane color and capillary refill time? Again, pull your book out. Take a look at box 31.1. If you're seeing anything in that box, you're going to need to tell that your doctor that you're seeing things that we may want to postpone the procedure. There are a few diagnostic tests that we like to do before we put an animal under anesthesia, that just helps us to kind of understand how we're going to need to support that animal under anesthesia. It helps us to supplement our history and physical assessment. It can help us to uncover abnormalities that aren't even really visible. Um, the puppy comes in super happy, and we do a test, and it looks like, oh my goodness, we have an infection going on somewhere in the body. We need to find that infection and deal with that before we do anything else. So we have high neutrophils, which are white cells that come in for an acute infection. We have low lymphocytes. We have high monocytes. There's definitely something going on here. And over here in our chemistry, we have high globulin, which is immunoglobulins, which is antibodies, which means we're fighting a disease, we're fighting an infection. I want to know that before I go in, because it may be an infection that causes a problem during anesthesia. Another really common thing that I see is, and these puppies are absolutely acting fine, is we'll start to see some increases in liver enzymes. And we see that when we have a problem with a liver, and we have to remember that the liver clears all of the drugs from the system. So if it's not clearing the drugs properly, this animal could stay under anesthesia for a long period of time, and it can cause some major issues. If we do find any abnormalities in our evaluation, we do need to stabilize the patient first. If they're if they there are only a few real true emergency surgeries that we have to go to surgery before we stabilize. One would be a tracheostomy, so we can make sure they are breathing. Another would be if they have bleeding inside, which even that, if we can do a blood transfusion first, we'll want to do that. Um, Dehydration, we want to fix that before anesthesia. Anemia, when they have low red cell count, we want to try to get that fixed before anesthesia. Cardiac arrhythmia, respiratory compromise. If we put them under anesthesia with respiratory compromise, we're likely to kill them. If we have major organ failure or electrolyte or acid-base imbalances, these are things that are going on in the blood that are just off. We need to fix those before we can put them under anesthesia, because all of that interferes with our ability to keep the animal alive during anesthesia. There's a Society of Anesthesiologists called ASA, American Society of Anesthesiologists, that give a subjective rating of condition. So they put them into classes um, that tell us how that animal is doing, and it's subjective. Meaning that we have to make that, it's kind of an opinion, but we make it based on a certain list of criteria. And again, this table is in 31.2 in your text. I pull that book out, turn the page, and take a look at that. ASA Class 1 is a very healthy animal. If it's a really healthy animal, but it's also an emergency surgery, we're going to put an E at the end of that. So ASA 1E would be a healthy animal that needs an emergency surgery. Or P1, patient 1, I guess. So P5 would be extreme. We've got an extreme case. This animal probably won't make it through anesthesia. This just helps us to guide what protocol we're going to use with the anesthesia. Protocol means what drugs, what delivery, how we're going to support them, etc. So anesthetic agents are classified in one of three ways: either the route of delivery, whether it's topical, oral, or injectable; the primary use, pre-anesthesia sedative; and the drug class, opioids versus sedatives versus tranquilizers. The most common anesthetic agents are called agonists, Agonists are drugs that bind to a receptor. So in order to cause an effect, we have receptors on cells, and we have to have something bind to it that changes the way that cell acts, right? Sends out messages, whatever it does. So agonists bind to receptors to exert a 1+ effect. So it's either going to do the same thing that happens in the body, or it's going to do it at more of an effect. So, for instance, we have endorphins in our body. Endorphins help to make us feel better. Um, those endorphins are being um, are being um, received by receptors that are opioid receptors. If I give an opioid like morphine, that's going to have more of an effect to make you feel better or calmer or sleepier or whatever than an endorphin would. Okay. An antagonist is the opposite of that. It blocks or reverses the effect of the agonist. These are reversal agents. So it will go in if we have something holding on to that receptor. An antagonist will come in and kick that out and block that, and not, so it allows the cell to go back to whatever normal is. So we call those reversal agents or antidotes. So those are antagonists. An example of one would be Narcan or naloxone. Kicks out morphine or heroin, things like that, to remove it from the receptor so that it's not causing such a severe effect. A partial agonist will bind to receptors and have a partial or mild effect, and mixed agonist-antagonists will reverse the effect of pure agonists. Anticholinergics, these are drugs that are given as pre-anesthetic agents, or as needed during anesthesia, and they just help support the body a little bit better. Parasympathetic nervous system blockade. So the parasympathetic system is activated by most of these anesthetic agents. Parasympathetic nervous system helps your body to rest and digest. So that resting part is the anesthesia. The block, an anticholinergic blocks that. So if you're resting, you have slow heart rate, which is bradycardia. Okay. If you're digesting, you have a lot of saliva because that's the first part of digestion. So something that blocks this is going to prevent bradycardia and prevent hypersalivation. The two anticholinergics that we use most commonly in veterinary medicine are atropine and glycopyrrolate. Atropine is rapid acting. It has small animal strengths and large animal strengths. So you have to make sure you don't mix those up. Glycopyrrolate is even quicker acting, but it lasts for a little bit or it's actually slower acting and it lasts for a little bit longer. It's a little bit more expensive, so we're not seeing it as much in private practice, but it is something that is very effective. So there are some potential side effects. So if you give too much of it or if the animal overreacts to it, we can see the heart speed up to the point where that we have tachycardia. It can cause cardiac arrhythmias. It can dilate the bronchioles too much, cause mydriasis, which is when the pupils get really large, and it can actually cause ileus, which is stopping the GI tract from moving normally. So some tranquilizers and sedatives that you're going to see that we use for minor procedures. We don't use gas anesthesia. We don't induce them to a deeper state of unconsciousness. Phenothiazine tranquilizers and benzodiazepine tranquilizers. Phenothiazine are major, so they do calm and sedate. We use them for pre-general anesthesia. One common one that we use is acepromazine. We do have to remember that there are no reversals for acepromazine, so we do have to be careful with it. Benzodiazepine is a minor one, so it doesn't work it's not as strong, so it's not going to put them under its effects as much. So we use it usually in combination with other agents to get a better effect. It's anxiolytic, which means it reduces anxiety, provides pain relief, and sedation. So those examples would be diazepam, which is Valium, midazolam, and zolazepam. They all end in PAM. The phenothiazines tend to um, end in zine. We also have alpha-2 adrenergic drugs. These are sedatives that are used alone or in combination with opioids, dissociatives, and other agents. They have a wide range of effects. Things like xylazine, dexmedetomidine, ditomidine, and romifidine, they end in INE, um, are sedatives, and we do often use those in combination, but they do have some analgesic properties as well. They are able to be reversed, which is terrific because that makes the drug even safer. So xylazine is reversed by yohimbine, dexmedetomidine and ditomidine are reversed by atipamezole, and romifidine is reversed by tolazoline. So you're going to be asking me, um, do I need to remember these medications? And my thought is, yeah, you should remember these common names. Do you need to remember right now what group they're in? Maybe not. Um, but it's a good thing to start to remember because you're going to need this information in the clinic and you're going to need this information when you're in my pharmacology class. So I would definitely start to make cards and flashcards and start to remember these. Opioids, these are stronger tranquilizers and sedatives. They also provide pain, pretty good pain relief, especially those agonists. And there's some other effects. Some of these can be used actually as a cough suppressant or to slow the intestinal tract. So there are a couple of different uses that we use with opioids. Agonists, usually their effects are at mu receptors, so there are a lot of different, there's mu and kappa and a couple of different receptors that endorphins are active at, so opioids as well. But it really kind of varies by species. So it's mostly we see some analgesia and sedation, but we have to be very careful with the species that we're using with. The other thing we have to be careful of is class 2 or agonists are class 2 controlled substances. That means that they're more difficult to get. You have to have a special form to fill out and contact the DEA, let them know you've got it in your hospital. You have a separate log for these class 2 controlled substances. They're highly regulated. Morphine, fentanyl, oxymorphone, hydromorphone, those are all common agonists. The reversals are naloxone or Narcan, naltrexone, which is Narcan, or butorphanol. Butorphanol is another uh, opioid, but it's a mixed agonist antagonist. So it partially can kick out morphine, but also provide a little bit milder pain relief. Buprenorphine is a partial agonist. It's kind of an agonist antagonist as well. It is a class 3. It's mostly pain relief, some sedation. It's class 3 controlled substance, as is butorphanol, which is a mixed agonist antagonist. And butorphanol can do some, like I said, it can be used as an antagonist, but also as an agonist. So it has some pain relief effect, a little bit of sedative. Going to talk about are dissociatives. These are cyclohexamines, and the ones that you will be most familiar with would be ketamine and tilletamine. Ketamine is actually a drug, a street drug that's used. It's called Special K. Um, so it is something that has been in the news. Injectable, it's an injectable anesthetic that can be used alone, but it only immobilizes patients for a minor, brief procedure. It does not provide anesthesia or pain relief. As a dissociative, what it does is it disconnects the brain from the body. So they're not able to think, oh my gosh, something's happening to my, or they could be thinking, something's happening to my body, but they can't do anything about it. So it doesn't change muscle tone. They're still sensitive to light and sound. They have intact reflexes, which means they can swallow and they can blink, although they don't blink often, so we have to protect them. They'll have an increased heart rate. It's pretty scary, actually, and increased blood pressure. Um, so it is a controlled substance. It is something that can be highly, highly, uh, um, what do you call it? Sorry, it's highly uh, addictive. Sorry, that's the word, addictive. So we want to be really careful with it in the hospital. We do usually want to give it with tranquilizers or sedatives or some analgesia, so we can reduce some of these adverse effects. We can give them something to calm the anxiety and to give them pain relief as well. This is something that used to be used frequently alone as an anesthetic product because it kept the animal from moving too much. But it's not effective. It's not something that we should be doing. I want to use it with other things. All right, the next thing that we can use is an induction agent. So these things also tranquilize or sedate, but they give us a deeper state of sedation so that we can they lose the tone in their jaw, and we can open up their mouth, and they lose their swallow reflex, and so we can get the tube into their throat. So both propofol and alfaxan, they're both short-acting IV anesthetics. They can be used to induce and maintain general anesthesia. So if we set up a drip in the fluid line, or if we give small amounts of propofol or alfaxan IV over time, we can do that. Propofol is a phenolic compound. It's not a controlled substance. It is a cloudy substance. We almost never give cloudy substances IV. There's only one or two of those that are given IV, and one of them, the main one that I want you to remember is propofol. We do have to be careful with the propofol because the way it's made, it supports bacterial growth. It's like a little culture. So we have to use aseptic technique when we get it out of the bottle, and we have to use aseptic technique when we put the bottle away and when we give the medication. And then we have to watch because if we give it too quickly, they will actually stop breathing. So we have to give it quickly enough to induce the anesthesia, but not so quickly that it stops their breathing. Alfaxan is a neuroactive steroid. It's not a controlled substance. It does support bacterial growth. So again, we want to use aseptic technique and monitor for respiratory depression. Some other miscellaneous things that we've used for general anesthesia or induction agents or for seizures or for euthanasia. Barbiturates are like phenobarbital or pentobarbital. Um, we can use them for anesthesia. In fact, euthanasia solution, Euthazol, is an overdose of anesthesia. It's just a really heavy dose of pentobarbital. Um, so there are different forms of barbiturates. There's an ultra short acting, a short acting, intermediate acting, and long acting. We'll go into that more in pharmacology. But barbiturates, euthanasia solution falls in that category of barbiturates. There's etomidate, which is an imidazole derivative. It's a hypnotic, which means that we can put them into a state of hypnosis they can be roused from. So there's no analgesic quality with that, but it is something that can be used. In horses, we use guafenicin. Guafenicin is a muscle relaxant and sedative. It's also known as an expectorant. It's in Mucinex. It's the medication that's in Mucinex. But it is something that we use as an anesthetic adjunct in horses. Our inhalant anesthetics, these are liquid agents that are vaporized in oxygen. So they're vaporized in these precision vaporizers because they have different different vaporization points. So they'll vaporize at different pressures. So they'll go from a liquid to a gas based on the amount of pressure that is put on the liquid. Um, The precision vaporizers will help us to measure exactly how much anesthesia we're giving to the dog. So it gives us a better dosage rate, so that we can be very careful with it. So vapor pressure is that measurement of the tendency of a liquid to evaporate. Agents with a high vapor pressure evaporate readily, reaching dangerously high concentrations if not regulated. And so we want to administer that with that agent-specific precision vaporizer. So you can see these are color-coded. This yellow one is for sevoflurane. This purple one is for isoflurane. These are the two that we use most often. The liquid is put into this box here, and this is the vaporizer here. Each inhalant anesthetic is a different chemical, and so they enter into the blood based on the size of the chemical, the size of the molecule. There's each one has a different blood gas partition coefficient, which is how quickly does it pass those membranes from the alveola to the capillaries and get into the bloodstream. Sevoflurane gets into the bloodstream faster than isoflurane. It also gets out of the bloodstream faster than isoflurane. So there are times when it's actually better to have sevoflurane than isoflurane. But there's also times where we don't want the patient to wake up quite as quickly, so isoflurane is appropriate. There's also something called the minimum alveolar concentration, or MAC, and each one of these has a different blood gas partition coefficient and different MAC. And we're going to use these properties to just help us decide which is the best one for this animal or this practice. The minimum alveolar concentration is how much gas, how many of those molecules have to be in the alveola before it'll be pushed into the blood. So that's how we decide, are we going to use isoflurane or sevoflurane. The anesthetic equipment looks really complicated, but it isn't. It's basically a closed system where we have a patient, and this is a rebreathing apparatus. So we have the inspiratory limbs. We have fresh gas come in. We have it go into the patient. We have them, when they breathe out, it comes through a different tube, and it comes out to the bag, and the pop-off valve, and a CO2 absorber to take away that. And then it's going to come back around, so they're rebreathing this, but we're getting we've taken the CO2 out, and we've got fresh gas coming in. We also use endotracheal tubes, so something to help maintain an open airway, minimize the risk of pulmonary aspiration of blood, stomach contents, etc. We're going to ease supplemental oxygen flow, and allow the anesthetist to ventilate the patient. So all of these things help us to breathe for the patient a little bit better. There are a lot of different types, and you can see an example here of the different types. Most of them that we use do have a balloon at the end that we want to blow up, and this is our pilot balloon. It tells us how much this big balloon, this cuff, has been blown up. What this does is it prevents, if this tube doesn't fill the entire trachea, it prevents any extra gas from coming out and leaking out. We do want to make sure that our endotracheal tube, let's see if we have it there, matches the size, as much as possible, the size of the trachea. The more we blow this balloon up, the tighter it gets at one spot in the trachea, and then more damage it can be due to that spot in the trachea. So it can cause coughing, it can cause damage to the trachea where we're actually cutting blood flow off. So it can cause some pretty severe issues. So we want to make sure that this tracheal tube is almost as big as the trachea itself. Okay, so we don't have to blow this balloon up a whole lot. A laryngoscope helps us to look back in the back of the mouth so we can see the larynx and see where we have to put the tube. It has a handle with a light source and a blade. Okay, and the blade sizes and shapes will be different based on the animal that you want to use it on. Anesthetic masks help us to administer oxygen or anesthetic gases if we don't have an intubated patient. so it is a little bit more dangerous. It's a lot more dangerous for you as a technician. The anesthetic chamber can be used to induce general anesthesia if we have a smaller patient that is not able to be handled. We can dump them in this box and close it up and have a fresh gas in and a exit waste gas. Got to fill this whole chamber up. So if we can put some towels or something in there to create less space so that the animal is able to just breathe the gas that is floating around free in the chamber, that helps us to anesthetize them a little bit faster. This is not safe either because you have to open this chamber up and release those gases. So it's a good idea to flush the chamber out quickly and remove the animal quickly, and then take the box outside to finish gassing off. The anesthetic machine delivers inhalant anesthetics and oxygen. So oxygen is what we call a carrier gas. It is the positive flow gas that takes that vaporized anesthetic gas with it. So we have to have oxygen flowing in order to take the gas to the patient. This is what's used during general anesthesia. We have our carrier gas supply, the oxygen here. B, and this red, is our vaporizer. This is part of A. This tells us what level our oxygen machines are at, what millimeters of mercury, or sorry, liters per minute, millimeters of mercury as well. We have also a C is this breathing circuit. So this is a rebreathing circuit, 2 tubes coming out. It passes the CO2 canister, and we have this rebreathing bag here. This blue is the scavenging system, this blue tube. And this scavenging system takes away the waste anesthetic gases that are so dangerous to you as a technician. You can see in box 31.2 of your book how to assemble the machine, how to check for leaks. And basically, we need to close off the system by putting our thumb over the tube, the end of the tube, turn on the oxygen until this bag fills up, and we measure the pressure. It should be about 20 millimeters of mercury, and we should see this pressure stay there. If it goes down at all once we have filled it up, that means we have a leak in one of the tubes, in the bag, that's probably the most common, or in one of the connections. So we have to check for leaks. If we do have a leak in the system, that means that the animal is not going to be anesthetized properly. They're either going to go down too deeply or not at all, and you're also going to be breathing that stuff. So we want to check for leaks every day, sometimes several times a day. We also want to set the pop-off valve. We want to open it up. If we do not open up the pop-off valve, it closes down the system and it doesn't allow air to exit the system. So we'll end up blowing up the lungs, and nobody wants to do that. So you want to always make sure that pop-off valve is up. The carrier gas supply, these are gases into which the liquid inhalant anesthetic evaporates and carries vapor to the patients. It's oxygen. It has a yoke, an outlet valve, and a valve stem. So here's the yoke. Here's the outlet valve. Here's the valve stem. This is a dangerous piece of equipment. It's one of the most dangerous things that we have in the veterinary hospital. This is a larger tank. This is an oxygen producing machine. We do have smaller tanks as well. Only the person who is trained to transport these tanks should transport them. Once they have them in position, they must be chained to the wall. If they fall over and this breaks off, this becomes a literal torpedo. It will go through walls, and it has killed people before. So you have to be very, very careful when using this equipment. The vaporizers are going to hold that, like I said, the liquid inhalant anesthetic. It's going to add vaporized anesthetic to the carrier gas, and the gas is going to carry it to the patient. The precision high vapor pressure inhalants that we use are for isoflurane and fluorine. There are some low vapor pressure inhalants that we don't use anymore. So we will have the vaporizer inlet port, outlet port, and fresh gas inlet. So here's the vaporizer, um, and we have the oxygen coming through here, carrying the gas through the fresh gas inlet into the tube to the patient. Breathing circuits, there are two that we typically will use in practice. The first is that tube one that we talked about is the closed or total rebreathing, or the total rebreathing system. We also have a semi-closed partial rebreathing system. This is one that we can open up. And then we have the non-rebreathing system. I'm going to show you that this is actually a non-rebreathing system. We have gas coming in, but the gas, when it goes out, goes straight to the scavenging system and does not go back into the patient. So here's the rebreathing. We have unidirectional flow valves, so going into the patient and coming out of the patient. And you'll see these flow valves here. They'll be moving as the patient breathes. This is the reservoir or rebreathing bag, the pop-off valve, relief valve, so we can close it down to close the system. We can open it up to allow air to exit the system. Our CO2 absorbent canister takes that waste CO2 out. We have a pressure manometer here that tells us how much pressure is in the system. If you go above 30, you're going to risk blowing open the alveoli and rupturing the lungs. We also have these negative pressure relief valve and a corrugated breathing tube. So these tubes are used for breathing. The scavenging system will transfer waste gas outside. There's the blue tube down. Gas that it needs. If it's too short, you're going to lose it into the trachea. So we need to have the right length as well. Having some gauze or IV tubing so we can tie it into place, a gauze sponge so that we can hold on to the tongue and pull it out so that we can visualize in the back of the mouth, a syringe to blow up that balloon cuff, an exam light or a laryngoscope, sometimes a stylet to make these little tiny tracheal tubes a little bit stiffer so that we can get it in, especially with cats. So nose to the length is nose to the thoracic inlet, so where the neck meets the body. Okay, that's just how long it should be. Shouldn't be any longer than that. We want to prevent, by having the proper length, we prevent hypoventilation, hypoxia, and dead space. So we want to make sure we have the proper length as well. Here's an example of somebody holding a pet for intubation, and they've got their fingers behind the canines and outside of the mouth as much as possible. If this animal bites down, you have to be careful. When we're looking at the tube, we want to make sure it hasn't been bit through by the previous patient. Make sure that the cuff is blowing up appropriately. And then we have a good attachment of this connector piece into the tube. Tubes do get washed and reused, so over time they can break down and have holes. You can see this person has the tongue. Now we never reach inside the mouth to get the tongue. You're going to push the tongue outside of the mouth with the tube, grab the tongue, open the mouth, and in the back you're going to see this. This is the epiglottis and the soft palate. If you pull down the epiglottis with your laryngoscope or with the tube itself, you're going to see the vocal folds and the arytenoid cartilage. And in between that is the glottis. The glottis is the opening to the trachea. Interestingly, for horses and adult cattle, this is how we intubate. So with horses, we do it blindly. Somebody holds the tongue, somebody puts a gag in the mouth, and we just work it down until we get it into their trachea over the tongue, and just wait for them to inspire, to breathe in. That'll open up their glottis and we can slide it in. Lots of lube, right? Cattle, we actually put a speculum in their mouth, open their mouth up, put our whole hand in the tube in, feel for the glottis, and stick it in there. So how do we know that it's in the right place? Not in the esophagus, which is the other tube beside the trachea, but actually in the tube or in the trachea. We can look at it. If it's a dog or cat, we can look and make sure it's in there. We can look at the bag to make sure it's expanding and contracting with each breath, that rebreathing bag. We can look at air movement. We can feel for air movement when they exhale. We can look at those unidirectional valves, inspiration, expiration. If they're moving, typically, that means that we're in the right spot. We should only feel the trachea. If we feel something beside the trachea, that means that the tube is in the esophagus. Vocalization. Remember, that tube goes inside the vocal folds. If no air is getting beyond the tube, that means that no air is touching the vocal folds, which means we're in the good spot. If they're vocalizing, it's not in there. And then we want to look at normal waveforms. So if we have a CO2 monitor or a capnograph hooked up, we should see CO2 coming out of that tube. So once we have it in, we do want to inflate the cuff, but we have to be very careful that we inflate it just to touch the trachea. If we overinflate it, it's going to press on the trachea and it's cut the blood, the tracheal capillary, and the blood supply to this area. Laryngospasm is a condition where the glottis will close during intubation, and we can do a lot of damage to that, those cartilage and the vocal folds if we try to push past that, because it's a really strong closure. We see it in cats, swine, and small ruminants most commonly. If we've irritated it enough, it won't open, so they will stop breathing. So we want to prevent it, and the way that we prevent it is we'll put some lidocaine to deaden this area here, a little lidocaine gel, and that will help us to open that up. To monitor anesthesia is the most important thing. This is the cornerstone of successful anesthesia. We want to look for those subtle warning signs that will tell us that the animal is dropping very quickly and is going over that edge. It does require quick action. Complications can develop quickly. We want to maintain kind of a balance. So we want to monitor them frequently. We usually say every 5 minutes, but you're checking all the time. Check multiple parameters. So don't just say, oh, yep, they're still breathing. You want to check their pulse ox. You want to check their pulse. You want to check their temperature. You want to check their carbon dioxide level. And don't leave it to the instrumentation. So instruments, if they're not placed correctly or they're not working correctly, are not going to tell you everything you want to know. So get your stethoscope in there. If you can do it safely and aseptically, get your hand on the patient. And don't judge your anesthetic depth by dose or setting. So don't look at it and say, well, every other animal does fine at 4%. You have to judge it by the patient. So check those reflexes. I have a video for you on stages and planes. This stuff will be part of some bonus information, so I highly recommend you take a look at it. So there are different stages of anesthesia. Stage 1 is a period of voluntary movement. This is when they're slightly sedated and they can still walk into the treatment area. Stage 2 would be a period of involuntary movement. That means that they are no longer in control of their movements, and they may thrash about, they may fall off the, the, um, the table, the treatment table, the surgery table. They may bark or bite, this is all involuntary movement. Stage 3 is the period of surgical anesthesia. That's where we want to be. Um, there are different planes in stage 3. So if we have a less painful procedure versus a more painful procedure, we want to pay more attention to those planes. Stage 4 is a period of anesthetic overdose. There's not a lot of space between stage 3 and stage 4, so you need to be very careful with that. So when we monitor, we should have an anesthesia record that we use, and this anesthesia record should go into the medical record. We want to observe our stages. So stage, is it, are we stage 1 or are we stage 3? And this has to do with what reflexes are still intact, where's their eye position, what's their jaw tone, how do they move in response to stimulation. There are different factors that influence their stage progression, and we want to get from stage as possible, so we kind of try to skip over stage 2 or go through it as quickly as we can. We do that through these IV agents, inhalant line here tells us where the isoflurane has been. This line here is the oxygen, and you'll note that we turn the oxygen on high when we start, especially with mask induction, and we want to start them on oxygen before we start them on anesthesia. And then we're going to lower it, and it's going to stay the same, and it's going to continue beyond when we do the turn off the isoflurane. This isoflurane is going to move more based on what's happening with their vital signs. So if we have an increase in heart rate, we're going to increase our isoflurane. Okay, so what we have here are this is a symbol that tells us we have blood pressure, we have pulse, and we have respiration here. And these numbers tell us where it is. So we should be able to look at this chart and understand why we turned up the isoflurane at different points and turned it down at different points. So there are two questions when we're monitoring. So the physical signs are that we're looking for are these two, answer these two questions. So is the patient safe or in danger? We're looking at vital signs. So indicators of circulation would be heart rate and rhythm, pulses, mucous membranes and capillary refill time, your blood pressure. Indicators of oxygenation would be their pulse ox, blood gas analysis. Yeah. Indicators of ventilation will be capnography and respiratory rate. Is their anesthetic depth inadequate, excessive, or appropriate for this procedure? Their reflexes will answer the second question. So if they're deep enough, they're not going to have a palpebral reflex or a very light one. If we squeeze their toe, a pedal reflex, and they feel it, that tells us they can feel pain. Muscle toe and jaw tone, if their eye position, depending on where their eye position is, if it's rolled back in their head, may be too heavy. Also their pupil size. And then response to surgical stimulation is a big thing too. So some equipment that we use esophageal stethoscopes. It goes directly into the esophagus and can go right up to the heart. It's easier to hear the heart. An EKG or ECG monitor can measure the electrical flow through the heart. Ultrasonic Doppler monitor detects blood flow through small arteries. An oscillometric blood pressure monitor, we can just put a cuff on there and read the blood pressure and the heart rate. A pulse oximeter measures the percent of blood saturation with the oxygen. An apnea monitor, I don't like. It just tells us, our anesthetists, if they stop breathing. By the time they stop breathing, it's too late. What I'd like to see is an end-tidal carbon dioxide monitor. This is a capnograph. It measures CO2 in the inspired and expired air, so it gives us this nice curve. Inspiration, we're not going to see a lot of CO2. Expiration, we're going to see more CO2. It is our best early warning system by far. It definitely tells us that they're doing well. In the horse and small animal versus horse versus ruminant, I'm going to talk about that. So with small animal, we're going to check the protocol, right dose, right route, right order, make sure we're doing it correctly for each animal, and then make sure that we understand the signalment, their pre-existing problems, their physical status class, and what procedure we're using. Make sure our equipment is all prepared, that it's gathered, it's checked, it's organized, there's a leak check that's happening, history or lab results, stabilize the patient, place our IV catheter, begin fluids if that's what our protocol calls for, and administer pre-medications. Then we're going to induce, we're going to administer just to effect and check their vitals, and then with IV, it's a very quick induction. We're going to put them on a tube. IM, it takes a little bit longer, usually a little bit more higher dose. With mask induction can be challenging because that inhalant anesthetic does smell, and so we want to make sure that they're getting that into their mouth and not flailing around. And then chamber induction may be something with a smaller aggressive pet. We want to maintain them at a desired plane. We want to, in order to do that, we want to evaluate their vitals and their reflexes and their jaw tone and their eye position. In order to do that, mostly we use inhalant anesthetics, but also we can use IV anesthetics as well. Once we have them properly under, we're going to put their patient in the proper position for our for the surgery, but also make sure they're comfortable and safe. When they recover, you got to think about a lot of different things. When do we transfer them? When do we extubate them? How long do we monitor them after? So we're going to stop the inhalant anesthetic. We're going to continue oxygen, remove all of our unnecessary equipment, so anything that we have them attached to that we don't need anymore. We want to keep the patient warm, the warmer that we can keep them. The anesthesia absolutely drops the body temperature very, very quickly, and so we want to try to keep them warm so that they wake up in time. And then we want to turn the patient. If they've been on one side for a while, it's going to collapse the lung on that side, so we want to turn the patient so that we expand that lung and we can get them to breathe all the oxygen in and all the anesthesia out. When we're monitoring, we want to keep them in a cage or keep them confined in some way so we can watch them and watch their mucous membranes and respirations. They are going to progress back through the stages and planes of anesthesia in the same way that they went down. So a rough induction means a rough recovery. We do want to be aware that if they had a rough induction, we want to prevent trauma. They may bang their head on the ground, things like that, as they wake up. We're going to extubate them when their swallowing reflex returns. So I want to see them swallow at least twice before I take that tube out. If it's a brachycephalic dog or a dog with a really long soft palate that can get in the way of breathing, I'm going to wait until they're practically chewing on the tube. I want to make sure they're really awake before I take that out. Post-anesthetic, so when we send them home, we're going to have to warn the client that they are going to be pretty loopy. We want to make sure that they restrict their food a little bit at first and just reintroduce water gradually. They may be a little nauseous afterwards, and just to monitor them closely. So what's different with equine anesthesia? Well, we have to worry about the animal's temperament, their whole they're huge, they're physical size. The effects of the inhalant anesthetics and the management of the recovery. We need to select a protocol based on a physical status class of P3 to P5. Um, uh, those are modified, and then we have our healthy ones, P1, P2. Prep is critical for equine anesthesia. We need hoists, hydraulic tables, recovery pads, ropes, and a whole team of people. So here's the pre-anesthetic horse. We have an animal that has generally a jugular catheter in. We've got them in a padded stall. We've got a handler holding their head. We have the squeeze gate here, and it's being held in place by a rope that we can let go gradually and allow them to kind of sink down on this padded floor. This is an animal that has been sedated. Okay, so this is sedated, and then we're going to induce and put them on the floor very carefully. One of the other things that we have to do with these guys is to rinse their mouth out because they can hold on to hay and stuff in their mouth. So we're going to rinse their mouth out. We're going to clean their feet, remove or wrap any shoes. If they're not sedated before the catheter, we're going to sedate the horse and position them. Once they're induced, so this is an induction stall here, it's all padded. Once they're induced, we have to hoist them up and get them onto a table that has a lot of padding. It protects their muscles and prominent nerves if we put them in lateral recumbency. In order to do that, we need to pull the forelimb closest to the table, so the one that's down, we want to pull that forward to protect them as much as possible. Maintaining anesthesia is difficult. There's a lot of different complications that occur. Hypoventilation, they're not breathing appropriately because they're just so big. So often we have to use a huge ventilator to make sure that we're moving air in and out of their lungs. This is a catheter, an arterial catheter. It's going into the facial artery. And this is something that we can use to monitor blood pressure, blood gases, and make sure that they're doing okay under anesthesia. Most of these procedures, or if we're doing gas anesthesia, most of those procedures last a fairly long time, so greater than an hour. If it's less than an hour, we can keep them under IV maintenance, so just do a drip IV. For recovery, we have to be very, very careful. We do not want them to stand too quickly. If they do and fall over, they can hurt themselves pretty badly. So we may place a nasopharyngeal tube just to keep them under light sedation, or just make sure that they can continue to breathe. We'll cover their eyes as they're waking up so they don't thrash about and they don't get scared. When they feel like we're going to extubate when they're swallowing, and then we're going to get out of the stall, because as soon as they start flailing around, they can hurt somebody. So you have ropes on their halter, on their tail, in a padded stall. This door is closed and there's padding on this door, and somebody's standing on the other end of that door and with the ropes, and they'll support them as they get up. As they wake up, we'll start to see nystagmus, which is lateral movement of the eyeballs. We'll start to paddling their limbs, and then they'll typically have a rough recovery. We'll extubate them. In order to extubate them, we want to make sure their nasal passage is unobstructed because they are obligate nasal breathers. Post anesthesia, we're going to keep them muzzled so they can't eat right away, but leave them free access to water. For cows, they have a very unique digestive physiology, so we don't always put them under full anesthesia. The pre-anesthetic fasting is crucial for these guys to reduce the size of the rumen, so it can be 24 to 36 hours. But we have to recognize that it decreases microbial activity, so we may have to support that later. To prepare, we'll need head gates, transporters, tilt tables, and suction. We don't always use a lot of pre-medication. They're very sensitive to xylazine, so we typically will start with an IV induction, put them in an induction stall, move them to a transporter, tilt them on a tilt table, We do put them in, when we do put them in sternal recumbency, we want their mouth lower than their pharynx. We don't have a lot of problems typically with general anesthesia. They're with the recovery, they usually are fine with just laying there and chewing their cud. Well, not really chewing their cud because they don't have a lot, but we do want to watch for excessive bloating, um, and make sure that they're eructating that rumen gas. We do want to extubate them when they're swallowing or coughing. With these bigger animals, we do need to force air and anesthetic gas into the lungs. So we use a big ventilator. So it's almost as big as you. We want to try to keep that patient alive if breathing fails. We can use manual ventilation if we don't have a mechanical ventilator, but it's a big bag and it's really hard to do. Uh, so with small animals, we use the bag, and we're going to breathe every 2 to 5 minutes in a normal patient that is breathing fine. We want to expand their lungs every 2 to 5 minutes. Anyway, if they're not breathing well, we want to breathe for them every 15 seconds for about 5 minutes. It just depends. Okay. Um, Intermittent mandatory ventilation in most large animal patients, we need to really expand those lungs. But also if we have an exposed thoracic cavity, so if we open the thoracic cavity, we have to breathe for them, or if we're using something that paralyzes the diaphragm or the, um, the muscles of inspiration and expiration. So some complications of ventilation, we do have to be very careful when we're using positive pressure. It will reduce venous pressure um, and drop the blood pressure. If we use too much pressure, we're going to blow out the lungs and cause a problem, and it will reduce cardiac output. If we give them too much volume, it can cause, so uh, if we give them too much volume and don't allow them to breathe out, that means that they're going to get a respiratory alkalosis. And so we need to allow that to happen. And if we're not doing it enough, then they're getting a respiratory acidosis. Or if we're doing it too much, I'm sorry, if they're breathing out carbon dioxide too much, we're hyperventilating for them. That can cause some problems. And if we're hypoventilating, that will cause problems. So some anesthetic problems and emergencies that we might see if we have a pre-existing condition. So we're going to do our history. If we have a geriatric, young, obese, or pregnant animal, we're going to change things a little bit. If they have an adverse drug reaction, there's not a whole lot we can do except that hopefully we're using a drug that can be reversed. Equipment malfunction, you can handle. Anesthetic overdose, you need to calculate correctly. Complications of surgery, that's the doctor's issue, and human error. Okay, so human error is where you can keep track of these things and not allow this to happen. So some common things that we'll see is that we don't have an oxygen tank that is full, or it's been turned off and not turned back on. The endotracheal tube is misplaced, disconnected, or blocked. The pop-off valve is too far closed or closed all the way. It's maladjusted or leaking scavenging system will cause problems. A high or inadequate oxygen flow, so too high or too low. Or if you use that flush valve, there's a flush valve on the oxygen. People like to use it to fill up their rebreathing bag. Not a good idea. Or you have saturation of your CO2 absorbent, you haven't changed it. So taking care of the machine and knowing how the machine works is really important. So if the patient is not staying asleep, it's usually an equipment problem. If they're too deep, it's because either the vaporizer is set too high, or we have equipment problems, or there are pre-existing conditions. If they go into cardiopulmonary arrest, it means that you did not correct the anesthetic depth. You allowed them to go too deep. If they're not breathing, apnea or hypoventilation often follows hyperventilation or induction with a respiratory depressant. So we have to be careful how quickly we give those drugs and making sure we don't breathe too much for them too quickly. Hypotension, there are several causes. Hypoxemia or low oxygen. We'll see cyanosis and dyspnea because they're not ventilating properly. Vomiting or regurgitation, we have to watch for pulmonary aspiration. So make sure that they are definitely fasted. Prolonged recovery, there are several causes. A lot of times it's because they're too cold, so making sure they're not losing too much body heat during the procedure, or they have a pre-existing disease. Um, or a rough recovery we'll see in non-premedicated patients. So if you have any questions, let's talk about it in class. I hope you took a lot of notes because there's a lot of information here.